It's hard.
All right, so you guys ready?
Yeah.
If you want to move closer, you can. If you want to stay kind of in your side of the room, you can do that. So this is Professor Mary Kitty from the Speech Language Pathology Audiology Department. These are first-year graduate students in our program. They're in their third, coming up to 3 years, they're in their second profession.
Great.
They've had one clinical experience of 8 weeks. They're about ready to go out one and a few more. Variety.
Okay.
Variety. So I'm going to go check the camera. It's your patient.
Okay.
So it's this side that's starting.
Okay. Hi. Hi, Annie. Good. Mary Kitty. Yeah.
We just have a couple of questions to get it back on what brings you to
I have back pain. So I don't know if, should I be like from me a year ago or do you want me to just be me today? I have back pain. Either way, I've got back pain.
Just like you are today.
Yes.
Just like if you were really going to peak.
Right. But more than it's my back, when I was pregnant 16 years ago, I had sciatica, and I was thinking it was sciatica too because it kind of goes down my butt. So it's not just my back; it goes down my butt and then my calves hurt.
the angle side?
Yeah.
So what particular activities do you do that you really see this sensation?
Well, I run 3 miles 3 times a week. And I actually think that I know this isn't your question, but I actually think that helps, but sometimes after, if I do more than that hurts. Standing is horrible. Sitting is, well, standing like if I'm not moving. So walking is great, but standing is the worst, just in one spot, like lecturing for long, like an hour and 15. And sitting, like I can't do a whole movie without really shifting or whatever. I get, in meetings, I'd say maybe I've got a good 20 minutes and then it just really starts to hurt.
Have you been doing anything to relieve that pain? As far as like medications?
Yes. Yeah, ibuprofen is my friend. I need to take more than the 2. I usually take 3 before a run. I pre-medicate for that. Or if I know, like if I'm going into almost every day, because I always know there's something that's going to yeah.
So, for the beginning of that, did you have a past history of back pain?
No.
This is the first occurrence.
Yes.
And it's lower back?
Yeah, but yeah, right.
Like that, I guess that's low back, right?
Yeah.
Almost like a little triangle, sort of. But then it's disturbing because
It goes down my leg. It goes down both legs, and then this calf issue is probably my biggest complaint. I just call it a back, because I know that's what's originating. Because if you say this, you have a leg pain,
Have you had diabetes or other health issues?
I have high blood pressure. That was on medication for a long, long time, but I'm off medication now.
So are you doing anything in particular to keep that balanced, or are you?
Yes, that's part of the running, and that's why I don't want to give it up, even though I do think it is a little bit worse after I run. But I need to do that cardio, and I hate the elliptical. So I like to run outside. So I'm doing that to keep my blood pressure down.
What kind of work do you do? Sitting, you said you talked about standing.
Yeah, so I manage the clinic over here at the speech clinic, so I do a lot of sitting, and then lecturing is standing. I mean, speech therapy is always sitting, it's not physical therapy, so we sit. Yeah, we sit. And then my home life is, just a single mom. It's pretty sedentary once I get home after I do my 3-mile run. So, yeah.
You have problems lifting?
Well, yeah. So there's 3 things I have to lift in my house that's 50 pounds. I heat my house by coal, which I know for you people from downstate think that's like out in the ocean. Yeah. So the bucket is 50 pounds. So now we just started that October. That's really heavy. So my daughter's, that's her new job. She's 16. Salt for the salt water is in 50-pound bags, and my big water bubbler or whatever. I feel it like as soon as I lift something, I can feel something compressing or something tugging. Yeah. Oh yeah.
So what's your immediate reaction after you feel that sort of pain? What do you do to sort of relieve it?
Well, I'm just trying to avoid that. I'm using that as a good enough reason not to do those children around the house. But yeah, I'm lifting things that are heavy. I mean, some of the stuff I have to do, and I just grin and bear it, and just try to use the right muscles.
So as, like you said, as far as other activities you really like, besides lifting, is there any you avoid lifting?
Yeah, so I avoid lifting. You can't avoid sitting, but sometimes when I get home, I have to get off my back. I have to lie down. And that's exactly what I say. I walk in the door and I'm like, say to my daughter, I just have to get off my back. I have to lay down for a little bit, and then I feel a little bit better, and then I can do stuff. The standing, sometimes I'll just, if it's bothering me, I'll say to my class, or if I didn't pre-medicate or it's worn off, I just have to sit. Well, I sit and lecture, I don't care. You know.
So do you drive?
I do, and I do go on a lot of long trips, and that is really problematic. Like I have a lumbar thing in my car, which helps a little bit. I try to stick a towel in there, but long drives really bother me, but not short drives.
Okay, so how old are you?
49 and holding. I'm staying here. 49. No, it's true, I am 49. I really am.
Are there any other recent lifestyle changes that you noted over the past couple of months?
Well, there's been a positive lifestyle change is that I've lost a significant amount of weight. I had been told, so I've had the back pain now for 2 years, but it took me a whole year. I was too busy. Those college professors, it's really hard to even make a doctor's appointment. You should appreciate us. I lived with it for a whole year until it got so bad. And I was well over 100 pounds overweight, and my primary care doctor just told me that my back would feel better if I lost weight. So I lost over 125 pounds, and in fact my back obviously didn't get better. So that's a positive thing, but not anything negative. Yes.
When your pain is at its worst, how intense would it be?
Yeah, so let's do that whole scale thing.
Scale of 1 to 10.
Love. First off, I should say that I've always been, even with weight on or weight off, I've always been really healthy, so that scale is really hard for me. I think I probably have a pretty high tolerance. The highest I ever rated it was a 6, and then, you know, people have said to me when they've looked at results like this, it probably was closer to a 9, but I think the highest was ever a 6. Right now it's a 3.
And have you sought physical therapy before?
I did.
And did that significantly decrease your symptoms and pain?
Okay, so the course was right after this MRI, which you'll see, I did have a course of physical therapy, which probably was, I think, 12 sessions. And we did a lot of core work. I felt like my core was okay for my running, but apparently it wasn't. I did get some benefit, but not as much as everyone had hoped, would have hoped.
Have you seen any other medical professionals outside your primary care physician or PT to help you?
No, I didn't, but I thought about it.
You say your pain goes down, like how would you describe that pain?
Okay, that's a great question. It's really interesting. So, like the 3 that I'm rating right now is probably here that I get from sitting, and then down my butt is more like a 4 or a 5. But the worst, the 6, is like as if I'm dragging a dead body. 2 people gripping my calves. I hate to be so melodramatic, but it's horrible. That's the horrible part. And that's what, like, when I say to people, like, oh, it's here. So that's why some of the athletic trainers, not to bash anyone if they have an athletic training background, but they had me on the roller thing because they were like building scar tissue, and I was rolling that for a whole year. I was rolling it for a year, thinking something was wrong with my calves.
Are you thinking athletic trainer or personal trainer?
Oh, thank you. Not, I don't know. The students that were up in this. I joined that mind, body, and me thing.
Personal trainer.
Thank you. So happy to clarify. I'm sorry. So in addition to the rolling thing, was told by those same people, I needed to get, it was for sure, my sneakers. So I got different sneakers that were $150, mind you, and my salary, that's a lot. Then I was told it's because I do the same 3 loops in my running. So then I needed to mix that up because I was told that the calf issue was that. And then I was told I needed it not by a personal trainer, just nobody important, that I needed a sleep number bed, that it was my bed, my mattress. So I was like, yeah, it was everywhere before I went to get real help and stuff.
So you like said you like grabbed your body, like a gripping,
Yes.
pain, a tingling.
Yeah, you know, when you have to fill out those,
Yeah.
just like that. Like I can do it to your leg and it would feel exactly like that. Like right now, this is what it's.
And what about the pain that goes down your leg?
It just does. It just, and the interesting thing is, so it goes down both sides of the butt, and then it takes this nice hiatus from here to here. It's great. My knees are great, and then it's the gripping here. So I don't know. I don't really want to say it's shooting because it's just kind of always there. So it's not like it shoots. It just is there, but I don't know how to describe that. And when it's really bad, I have this thing, like it feels like a spider maybe, or a snake or something. Like it just does this like weird sort of what I call a spider web thing or something. I guess that would be more like tingly kind of. It doesn't hurt so much as it's just creepy.
And when did you say the pain started and noticing?
Yeah. 2 years ago. It sort of started with, I thought a good idea was to fill my potholes in my driveway and save $200. Somebody said they had extra gravel. So it started, the whole reason I think I got down a garden path is it actually started with like me feeling like I hurt my back. And then it turned into something bigger. So that was, the shoveling of the driveway was 2 years ago. This date, which is May, makes sense because that was like after the winter, so that was May 2 years ago, and then this was May of last year, the MRI, which is
Have you had any surgery for this?
no, not for the back.
But where else have you had surgery?
Tonsils, bunions, and a C-section for my daughter, but nothing that would be related. Right? And all of those were over 30 years ago for, you know, and 16 years ago.
So maybe 1 or 2 more questions just to kind of move us along, unless you think
Sorry.
you guys want to spend. No, man, I'm debating.
I can come back.
No, we have 2 hours too. But we have other things that we're going to do.
Okay.
I'm just debating. So if there's real burning questions.
Do you have you used like tobacco products?
No. Like, oh, alcohol.
We had dinner the other night. I saw you drinking.
Yeah, I know. No. Yes, I try to always have a good glass of wine with my dinner. No tobacco. That stuff will kill you.
Do you have any difficulty sleeping at all? Is there a
Yeah.
position that you prefer, or anyone that makes it work?
It's hard to find a good position. Yeah, sideline is good. This is I don't know what this is called, but just this is good.
So you put a pillow underneath your leg?
It's best if I do, but sometimes I don't have one. So yeah, like in my office. Sometimes I just have to get off it, you know, just for a minute.
So give us a summary of your important findings and maybe differential diagnosis, like top things that you think you need to sort out of what you it may be, it may not be, however you want to address that. You guys are important findings. Real relevant. All right, so leg symptoms, bilateral, back, buttock, and calf, not thigh. Seems to, may follow a dermatome, or it does, or, okay?
Did I mention that any sort of flexion, is that what it's called, flexion? Oh, I can't do it. Yeah, I can't go back at all. That really kills. I don't know if that's important.
It's up to them to decide whether that's important. We're going to look
But
at
it hurts
too.
a lot.
Any other important findings? Things that will impact your intervention and your diagnosis. Better with walking, work, no, say that again? Better with walking. Was that consistent across the board? Was that?
It's definitely worse with sitting and standing. Worse with sitting, standing, better with walking.
Maybe I misheard you.
Oh,
So
it
it
is
wasn't-
better with walking.
It wasn't consistent, at least what I heard, because I heard her one time say that she sometimes tells the class, I just gotta sit down.
Oh, yeah, well, I mean, there's a hierarchy, right? Standing is the worst, and then you get off it and sitting, and then if you sit too long, you have to get off it, and then it's sideline.
So sitting relieves it, but not for too long, and then sitting
Right.
makes it worse, and so some of this change of position. And I'm not saying she lied or I misheard, I'm just trying to make sure we understand each other, and if there's inconsistencies, trying to sort that out. And sometimes things just don't fit with a lot of other
Right,
findings. Like this all makes a nice pretty picture, but then you get this
right.
over here that you can't fit in and you want to. So what could it be? What are you thinking it could be that you want to investigate and sort out? Why? Bilateral, leg, seems to get worse in the legs with extension. What else could it be?
Posture.
What do you mean?
Meaning just the dysfunction between the normal biomechanics and what it should be, causing muscle imbalance, right?
Might cause, could that cause her leg symptoms?
Well, it's excessive anterior causing those lumbar.
Kind of then leading into, if it closes, kind of back into stenosis. And so there could be a tie between postures, positions, symptoms, and, okay? What else is on your list, hopefully? Disc, okay? What doesn't fit with disc? The bilateral, so we can figure that out. It could be, if it was bilateral disc, where would the disc bulge be? Posterior, central, okay? Or maybe two levels, one to the right, one to the left. See how you can start to make sense out of this. On the one side of your sheet where it said yellow flags, any yellow flags? Psychosocial, emotional things that you gotta kind of consider in here. I caught it one. There could be more.
Very dramatic. Tends to
No.
exaggerate.
I don't mean that. I don't mean is she crazy? Is she bipolar? I don't mean that. What we mean is psychological, social, emotional factors that may play into intervention, diagnosis, etc. She said a big one, I thought. A real big one. Well, it's related to the lost weight and it's related to the blood pressure.
She said she would keep running.
Right. So she just told you, listen, I don't care what we do, I'm going to keep running. Okay. So that, to me, that's a big one. You got to sort out, is running making her better or is it making her worse? And if it's making her worse and she's going to keep running, how are we going to sort that out? Okay. And it's medical as well. It's dropped her blood pressure, she's healthier, it's important, it's who she is now. And so you got to figure, you got to fit that one in. So that to me was a big yellow flag. And I think that helps you to understand yellow flags. They're not always, I mean, they can be subtle like that, but yet important. Other things to add with everything that you've heard? These guys are up here looking at MRIs and having a great time. They got a good story to tell you once we get to that. So there's parts of
Is the reason why you don't want to extend because of pain or the tightness or?
Oh, no, it's pain.
I'm just saying when you lift up it's
Yeah, so I feel like, and I don't exactly know how the back works, but I feel like the lifting makes it compress or something, like it's really like here, whereas like even this much, I feel significantly, then it just shoots shoots, so it's a sort of different pain. It's not just here. So those other personal fitness people thought I needed yoga. And you know how many, I thought because that hurt, that doing more of that was better to stretch things, and I actually was making it so much worse doing yoga. And hot yoga, no less, which wasn't good for my blood pressure. So I was aggravating it because I didn't go to the right people.
So what doesn't fit with stenosis with her story? Remember the story that I've told you, the classical, and if you came to the review session when Max was there and he had just seen somebody with stenosis and what the story they told, which is the same story I told you.
Walking makes it worse. Walking makes it worse.
Walking, and so what does she do? Run, and she gets better.
It's not throughout the whole lower extremity, it's just the.
Well,
Oh, I should tell you that my
And that
running
could be
is
the
really,
neurologic.
like, it's a 12-minute mile. I mean, most people can walk faster than I run, you know, so it's not that.
what would you expect symptoms to be when she runs? Better or worse?
Worse.
Worse. And if it's stenosis, how would you explain that? How would you explain why running doesn't make her worse if her diagnosis is indeed stenosis? Remember when we talked about things don't fit, you got to try and sort them out and see if they do fit. So we might want to watch her run on the treadmill and see what her posture is. Maybe she's learned to run more like this rather than run like this.
Well, I don't run like that.
Why? What happens if you run like
It
this?
hurts.
Where does it hurt?
The
And so
butt.
now you started to make it fit. So maybe she's learned, and this is what we talked about with treating stenosis. Teach them new postures, maybe posterior pelvic tilt.
Plus, I really tried to engage the core because of the small amount of physical therapy I had. So I am almost always like in that kind of crunchy, like when I'm running. 'Cause I'm not
That wasn't
running.
planned, trust me. We didn't plan this, other than we talked for 5 minutes and said you can do it.
Yeah,
So
yeah, you got
that's,
issues.
That's exactly what I'm what I'm about. Yeah, you got issues.
I just wanted to clarify, you said when you pick things up and when you're saying it said it feels like compressed, does that
Yeah.
mean you don't feel it going down the leg anymore? You feel it?
I don't know, I haven't really thought about it so much, but no, it seems like that becomes like more of a this issue, not a leg issue.
Okay.
But I don't know. I can go to something else.
Okay? How about we do the next step, observation, and because we started to do some observation of running postures, or at least a little bit, and then range of motion.
Hi. Nathan Sarp, how are you?
Hi.
All right, what we're going to do now is just go through some range of motion with you.
Great.
Just for the camera's sake, would you mind kind of like
Sure.
standing right in front of the room?
Mm-hmm.
So this section is so it faces this way.
Okay.
So we're going to break it up. You guys look at the anterior. You guys can get posterior. You guys get side. We'll talk about it. All right.
That's not my best side.
Don't worry about it. It's not mine either. So let's first start by going down and touching your shoulders.
Okay.
And let me know when and if any signs and symptoms you create.
Nope, I'm good at that. I
Good
can
at that?
do that.
All right, so let's try it one more time, except
Okay.
take it slower for us.
Okay.
Right.
Maybe when it gets to the very end, but that just feels like regular
Like a
hammy
s-
type.
it's
of-
a-
Yeah, I think that's just old age.
All right, so we'll save the extension, the moving backwards for last, just because you said
Yep.
it hurts. So let's try going to the side, keeping those hips facing one way, and just turning your trunk.
Mm. Twist a little bit, right
Where?
here, right here.
Can you guys see where? Back, same spot? All right.
Yeah.
And no pain peripheral, like down?
You know, there's a certain amount of pain that I just have, right, you know, that, not any more pain doing that. Let's just say that stays at the regular pain amount.
Pain now, okay?
Yeah, I'm good like that.
All right, so try it one more time this way. Just keep your trunk focused right there. And no pain that way?
Like a little twinge,
A twinge of pain, okay? And then let's try it to the other side.
same little twinge.
All right, so this time I'm actually going to hold your hips, and I want you to just move left. Okay? So I'm going to hold and move to the left.
Oh.
There we go. All right, any pain with that?
Yeah, just like on this side, just a little twinge.
Okay, right down there.
Yeah.
And then one more motion before we get to the fun one. Right there. Any pain with that?
Not necessarily, no.
All right, now to the other side.
No.
All right, now to the fun one.
All right.
All right, I want you to let me know if at any point, I'll be right here to catch you just in case. Come on. Let's go right back, as far back as you can go.
Yeah, like even here, it's starting to hurt her. So you want me to, yep, right now it's in my calf.
Okay, stop then. All right, you can go ahead and actually have a seat or however you're comfortable.
Yeah, it just does. I don't know, it just hurts a lot.
All right. Does anybody else want to, from my group, go up and do something? Thanks, guys.
Is that your own sitting posture?
You should have me do the, oh, I'm back. Like, yeah.
Hey, check the PSI of the
Well, hip height was.
You should have me do this one with the light one. Oh, is that yours out there? Somebody should have.
Next group.
That hurts.
Yeah, we'll wait for that.
Okay.
All right, well, thanks for letting me.
Thank you.
Just kind of summary from your group, main important findings that would lead into your motion testing, physical testing that you think need to be investigated.
Well, with extension, it looked like she did a lot more of thoracic as opposed to lumbar. Kind of looked like she kind of just leaned back as opposed to being that full movement. So maybe an area of hypermobility.
Hypo where?
In the lumbar.
Okay, or considering what you know from history, why would she choose to extend this way rather than this way?
Pain.
So it could be a learned compensation, and so we could
I know
investigate
it's
that
gonna
further
hurt,
by,
yeah.
what about bending down here, bending backward down here? And she'd probably tell you, no thanks, that'll hurt too much, would be my guess.
I'll do it.
And
For
some people would do it
science.
for you, but for science, all in science. So that kind of compensated, we got to investigate, is it a change in habit from symptoms, learned behavior, or is it a hypomobility in the lumbar spine into extension, down, glide, closing? Other major significant findings? Tight hamstrings? So overall motion, she got to the floor pretty good. What
But
about-
you know that test where you have to hit the I can't even move it, it's smidge.
So we can
Not at
definitely,
all.
it's easy to test, 99.
Barely, if I had a long fingernail, maybe I would touch it.
Other significant findings that anybody saw that leading you into your motion testing?
The rotation component, she had a little twinge with right rotation.
Right-sided lumbar pain with
Right rotation.
left rotation, is that an opening or a closing? So if it's right-sided and let's say we're thinking it might be facet, what's happening?
Closing. Left rotation causes
A couple of motions to the same side or opposite? Opposite. So it's easier for me to see what happens with side bending. If we're thinking about the right side and I left side bend, is it open or closed on the left? I'm sorry, on the right. My left side bend on the right. It opens, so then it'll be the opposite for the rotation. That helps. Okay. It's also what we're getting to and kind of working on in lab. So if it doesn't, if you're not sure, put in the back of your mind, right-sided pain with left rotation, it might help you to sort out.
When you rotated, was the pain just kind of like where you were pointing, or did it travel
Yeah,
anywhere?
it didn't really travel, I don't think. No, no.
So what test you want to do for motion testing? It sounds like we want to do 90-90. If we add in for you guys over there, special test, sounds like we want to do straight leg raise. She told you, oh, you got to try.
Wait till the end.
So straight leg raise sitting, and probably sitting slow, similar test. What about pivots?
We'll do spring, but if we're sure it's an extension. Put her in that position.
Okay.
I could maybe test her about
So you could look at spinous. So let's go ahead and do that.
Hi, Mary, I'm Paige. Hi, Paige. You can take a.
We're doing this table.
There's a little way down here.
You can,
So how are you feeling?
I'm good.
That's a comfortable position for you?
Yeah.
I have a pillow too,
Yeah, that hurts.
So what are you feeling for and looking for? And you guys all should be thinking of.
Motion and reproduction of her symptoms.
So amount of motion, willingness to move, or kind of quality of that motion compared to other segments, and then symptoms.
Not really hurt, but hurt more when you're lower. It felt fine when you were higher, but when you get, well, a little lower.
At that threshold.
So the other thing to appreciate, and when we tell you patients will walk you to the problem,
There,
just walk
that
you
would
to
be
the problem.
another one. With, a moderate amount of pressure doesn't hurt, but then when you start to go, then it feels like
maybe a little bit more with the cat. I have a fair amount of caffeine right now, so it's really kind of hard for me to know if it needs more. So I don't know.
So when I push down, do you feel it just where I'm pushing?
Okay, go ahead and do it. Yeah.
It's just where I'm
It might go to the back. My back is wrong.
I also didn't medicate today knowing I was coming because I wanted to be in peace.
So nice of you.
Well, I figured if you were saying does it hurt, does it hurt?
Like this with like movement mod. Like I can't even really test the motion of that segment. I can't get through to the image. So if
Yeah.
How do you feel lying like that?
Okay, so
What level?
that's a good question too, because you know when you're sleeping and then you have to switch like to lift up, it's hard. It's really hard. Right. It's really hard. So I almost thought I didn't want a pillow, but once I get here, I'm okay. But like if I do more than that, that hurts.
As long as I can kind of stay low.
So here's a question for you. Remember the continual thinking process. You think it might be stenosis, you put them prone, what could happen to symptoms? Could get worse, are they? So you said her calves were throbbing. Maybe that's worse than consistent with the stenosis. And Paige said, well, I'm going to give you a pillow, which makes absolute sense. What would you want to do with the pillow?
Put it like this.
The position here, what's it doing? More extension. So this is where it gets fun to play around with patients. Make them worse, make them better. This is that kind of sorting out what should I do and what's the symptom response. So the difficult thing with this table is this isn't one of the tables that easily drops. Some of our other tables, you can drop the head. Some of the heads into flexion pretty easy. I think you gotta,
We can see that bar.
or does it, does that one?
Yeah, this one's just
One that
more
drops.
new.
Yeah.
Do they smell it badly?
Lift it up and then.
I think it's as low as it goes.
I don't think that one.
your legs feel better.
So it just goes up.
I think the middle pulls up.
Yeah.
Okay, she feels better.
We're good. I saw your problem.
Am I too heavy?
Yeah, some of them split in the middle and go up. We could put the pillow under our hips. Maybe a bolster or.
You want me to?
Or what's another way to get flexion? Arch.
Go as far.
So the,
That tabletop thing?
Where you go up like a cat.
Yeah, well,
Depends
the
on-
up like a cat, I think is fine, down like a donkey. Yeah.
so this is again where if you listen to them, they'll tell you how to treat them. She's telling you everything that's helped and you work on it. So we got to do other tests. Do you want? Is it? Space.
Yeah, I could do boost flexion. Do you want to lay on your side? Sure. No, I can help you. And just scoot out to the end. Okay, towards me.
Oh.
Okay. Are you comfortable there?
Yeah.
Yeah.
Wash out, flip over.
You weren't facing.
I know, but I can't do this.
But you weren't facing.
This is the last thing that you guys learned, so that you guys are just practicing. So if it's cloudy in some of your heads, and clear in others, that's why. This
I was just gonna do it both on that side.
I understand, so that people can see and you didn't have to move. This is the last thing that we learned, so. Go ahead. So now this is helping you sort out kind of that postural issue. Is she stuck in extension? Can she flex? Can she gap?
None of this hurt at all.
If this were a disc issue, and if it was real irritable, moving into flexion like this, would you expect them to say this feels really good or feels like it's making it worse? Which direction would you think it's worse? Might make it worse. And she's saying this feels great, keep going. So again, consistent with the stenosis.
Well,
It's a
the other
po-
thing, Mike,
Yeah,
aren't I kind of young for stenosis?
I don't know, ask them.
A little bit.
Mary, just realized that to them, 49 is age. I'm 49 too, I'm 48 and a half, but I mean, you guys typically think, you see this patient on paper, well, 49, they're kind of older, so maybe they won't tolerate exercise.
So what would be the issue? What do you think? Does somebody just automatically have stenosis? How does stenosis develop over time? So repetitive motion, trauma. So did you ask the history of medical history of low back injuries or what was the answer? Okay, what else? Any episodes of low back pain over the years?
Just that bucket of gravel. Yeah, just that bucket of gravel thing. It wasn't just one practice, but I don't feel like I have any repetitive.
No history of that.
No.
Didn't you say like 16 years ago she was pregnant and had that?
Right? Also like
She has sucked the life out of me ever since.
During that time, did you feel bad? During pregnancy or?
No, sciatica I think is normal during pregnancy. I mean, I guess you know more than I do. But,
I would say normal. It wouldn't happen. So did you have?
well, maybe it wasn't related to the pregnancy. Maybe I just had it during that. It went away as quickly as it.
When was the bucket graph?
2 years ago. It wasn't just
Where
bucket
did she
graph,
have
it was
like
the
a
whole graph.
stenosis thing from? She said she recently lost like 125 pounds due to increased weight, putting more pressure on her rheumatoid and was causing this functionality.
What about hereditary? Because my mom has it. Yeah, but she's old. And that's why she
Maybe she
keeps
did
saying.
start developing symptoms.
Well, that's the thing. I mean, that's sort of her argument is you're too young. I didn't start, like, so she's like 76 or something. Yeah.
Young.
Yeah.
Is it possible for somebody to have stenosis and a disc problem at the same time?
Yeah.
So be on the lookout for that. I mean, that's possible. Does it seem like she does? Okay, so you guys are still all kind of leaning towards stenosis?
So we got pain with PA at L405, that's what lower lumbar, submental spine, space, restriction L405. Why don't you sit?
I
Why don't
just
you face
needed-
face the whiteboard? And you go check the channel.
So all you have to do is slouch down. And you can head down.
But not as much.
It was part of the
Would you do it right now?
Yeah.
No, I, yeah, you
What's the purpose of this test? To see if it's a unilateral or a bilateral restriction. So we're going to do it if we found a restriction. And if you feel one side more superficial, then it's telling you it's a unilateral. What happens if you found a restriction in interspinal space, but they felt symmetric? Both sides. It's a bilateral.
Is it up? It's not really like.
Why don't you check?
And it wasn't overweight my whole life. It was just, it was, you know what I mean? That was a
you're
short.
responding to,
Yeah, I was thinking, no, I like the way you're thinking, because I'm sure it wasn't great, but it wasn't on for, I know it was a lot of weight, but it was on for, I don't know,
It's gone
Okay,
now.
so
10 years.
We're gonna do this position for like uncomfortable for you. You want to lay on your stomach, and you're gonna prop yourself up on your elbows. Another one.
Not horrible.
It's not really.
It's like if I do more arching, that hurts, like right.
Arching through.
Okay, so like that, this didn't hurt so much. Getting into this position kind of is a little bit, but like if I go like that hurts a lot. And that goes right to the ass. Like that. Just that little difference.
Yeah, definitely.
Carly? Oh, your favorite one.
Yeah.
Hi, I'm Carly. I'm gonna have you go back over on the other side. We're gonna do
Like on
your back, yeah.
like
Yeah, on your back is fine. Okay, so I'm going to you're just gonna relax your leg, and I'm gonna hold it in my arm, and I'm just gonna start lifting it up a little bit, and just let me know when, where you feel any symptoms come back.
And I haven't actually probably done this for a year, so maybe it hurt when.
Okay, just let me know. So just relax. No, it's not.
So far, so good.
Okay, what if can you lift your head up off the pillow at all? Just relax.
Yeah.
That, okay.
Yeah.
Where did you get that fell all the way down?
Yeah.
Okay.
Here and all the way there, yeah.
All right, we don't do that again then.
So an important question is, we ran down which leg, or both legs?
Oh, okay, this
Would
one
you-
more. You can do it again, just for me to be sure. I mean, I think it's fine. And then lifting my head?
Yeah.
Yeah, that's this leg.
Did you feel anything down this one?
No, not really, no. But like really, right, like 3 key points. Low back, butt,
Nice and crack. Okay.
yeah.
Gotcha.
I mean, nothing else?
Not really, no.
Not really?
Let's go with no. Maybe a tiny little bit here, but not in the back.
Okay.
Yeah.
Alright, we'll try this one to see when this one's the most.
Yeah, nothing, just not with.
And then just look up a little bit how you feel.
Okay, that hurt a lot. Let me try to figure out where.
Just keep your leg nice and relaxed.
Okay, definitely in the low back. Feels like still maybe this side, but maybe a little bit more in the calf. I don't
So
want to
right
be
leg was that?
confusing. Yeah.
So if you lift what you think is the symptomatic leg, or if you lift a leg and you get symptoms in the other leg, that can be a form of the cross straight leg raise test. Did you guys talk about cross straight leg raise? Straight leg raise? We talked about it at one point, and maybe
This was way worse, whatever that means.
Alright, I'm gonna have you sit up for me.
put it in my notebook of the thing to talk about.
Have you sit up for me to face the class if you can.
Just remind, remember this, that one works, just in case there's any bulging somewhere. As opposed to just.
All right, have you sit up for me then? All right, okay, I'm just gonna have you again, sit at the edge of the table and I'm gonna move your leg.
Okay.
You can move back a little bit.
Oh.
Just so you don't- And all I'm gonna do is I'm again just gonna straighten it up for you.
Okay.
First, what I want you to do is just kind of assume a very short posture. So kind of just slope down as much as you can for a head.
Okay, that's kind of pretty right now. Okay, all right.
So keep that, and then let me know if anything that I do, I'm just gonna move your leg so you can keep nice and relaxed.
Okay. No, not particularly. Well, that I think is just hamstring stuff.
Okay.
That, this part, I think
Okay,
that's
that's
just,
all right.
okay.
So this isn't, again, lean as far forward as you can, so far forward.
No, not these symptoms, just tight. All right, well there you go, you successfully. Okay. Yeah, that went pretty quick.
Okay. So again, put your leg right down. So again, don't move your leg at all, okay? I'll do it for you. And then put your chin right down to your chest. And then let me know when you feel it.
Actually, just putting my chin to my chest now hurts. I don't know why. I mean,
Hair all the way down the leg.
both sides. That hurts a lot, actually.
So
what
with-
kind of pain do you feel?
Okay, it's both sides, right on, mostly the butt and then going to the calf. I mean, just doing that.
Is it that achy pain? Do you feel any of those
Yeah.
tingles? Like
It's like constant, pain.
Here's a question for you guys to think about. With these two tests, straight leg raise, sitting slump, when you wind up the neurologic system, either from, we're thinking about low back, so from the superior or the inferior, which one seems to be more provocative of her symptoms? Superior. On the superior side. Maybe that's useful information.
Okay, so we're gonna go over the imaging, but if you look at this, the history of low back, bilateral buttocks, leg pain, range of motion, pain with back bending, reproduces her buttocks and leg symptoms. She's got hypermobility and L4, L5, S1. She's got adverse neurodynamics with the positive straight leg raise and positive slump. What are you guys thinking? What's the diagnosis? What's the pathoanatomical diagnosis? What do you guys say? So you're going to say stenosis? Is it central canal, lateral? Central?
What makes you say central canal? Why not bilateral foraminal?
Either or.
Don't get talked out of it so quick. Make a case for potentially being central canal. At least in my mind, where I think this kind of stuff maybe there's some central canal and is it common to get both? Yeah.
The reflexes, this side is very poor. Andy Getson was like pounding on it. It was like,
But they're okay on the left side.
yeah.
So let's do this. We can check reflexes, but I think you may get more out of looking at MRIs and kind of going through what we can see.
Okay, so.
If you guys need to move closer because the images are only, and we can enlarge them out.
We need to lighten it up, Joe. We need to lighten it up, Joe.
Okay, so
This can lighten it up.
Lighten it up.
It needs to be lighter, you guys can see that?
Yeah, you can't see it.
You can't see that. You can see the white really well. Great.
There you go.
Thank you.
All right, so this is
I'm not just a whiner.
okay, so this is a T2 weighted image MRI, and obviously a lateral view. You look at the spinal canal, spinal fluid. There's definitely stenosis here from a herniated disc. If you look at the disc health, this is kind of a normal disc health. It's white, shows up with white. And this darkened disc, this is a very degenerative disc at L5, S1.
Did you guys know T2 versus T1 weighted images?
Yeah, we learned it in the color history.
The opposite colors representing.
Okay.
And if you look at this vertebral body, that's why we teach it in class. So here's the vertebral bodies, and it's starting to show some lipping. So maybe over time there was some hypermobility pulling on the bone. But you definitely have some stenosis in this degeneration. These are helping with this. So where do we find the stiffness? We found it at L405 by S1.
What is the S1 bar?
The sacrum.
Oh.
So the sacrum is 5 diffuse sacral vertebra.
Which vertebrae is the S1 then? Oh, right, okay.
And so this is the fifth lumbar vertebra.
Right, the last.
And you can see the remnants of the disc in the sacral vertebra. Okay.
Now what about this darkened area, like right here? Is that anything?
On the front? No, that's just ligaments.
Okay.
All that section. Okay, so, actually, let me.
I know, I feel great.
So as we go down on one side, this is looking, I'll let this up. This is looking through the legs. So here's your feet. Okay, this is the right side. This is the left side. We're going to compare levels. As I go down with this, we're going to look at the different levels of the lumbar spine. Okay, so here we go. We go down to the L4, L5 level. This is the spinal canal. How's that look? Small, right? These facet joints, this is the facet joint here, it's gotten really thick. So over time you get facet hypertrophy. Facet hypertrophy is what's causing lateral stenosis. So this is the space where nerve root is exiting. This is the space holding the spinal cord. Very small. So you can see where even from the compressing foramen or even from the central disc herniation, so that disc herniation really isn't posterior lateral, it's central, right into the ground. Because that disc is degraded, it probably won't retract back. Sometimes the disc is still healthy, you can look over time, it will get better. But you've got facet hypertrophy, and you've got a central disc herniation, which makes the space narrow. Even if you had just a central disc herniation, these facet joints weren't so thick. See how thick that is? That's all bony buildup over time. Usually that comes from some kind of stress over time. It's hypermobility. You know, an example would be someone injures their back. They don't have good motor control at that level. They get incidental movement of the facets, increased stress. The body responds by laying down more bone, just like anywhere in the body. And it gets thicker and thicker over time. And you get stenosis. That's why I said stenosis just doesn't happen. Now you can be born, or genetically as you mature, have a more narrow spinal canal. But if it happens from stress or trauma, repetitive use, it's usually because that motion segment is moving too much and is not stabilized enough. You get stressed to the facet joints. And when those facet joints aren't nice and stable and moving, and they're all over the place, the body lays down more bone. And that's what happens. You get thickening of that canal.
Can the surgeon like scrape it out?
You can have a roto-rooter. I mean, they take,
Yeah.
what they do is, unfortunately, with stenosis, they take off, this is the spinous process, this is the lamina. You've heard of laminectomy, right? So we
Yeah.
talk about laminectomy. You take a window out of that bone, so you move that piece of bone so there's more space. Sometimes they cut here and they cut here and they take that whole back off. So there's no back to the vertebra. And then the spinal cord has space. Basically, you've got this pushing this way, so let's take off this. So it can kind of move.
So the surgery is called a laminectomy?
Laminectomy, you can have a unilateral one side or a bilateral both sides.
We'll talk about that at the end of the semester, surgical procedure.
See it? I want to, you don't see it.
Yep, absolutely. So unfortunately, we can't get up that high. But can you see the difference in the space?
Yeah.
Look how much space is there at the level above. Look how much space the spinal cord has. So you still have a little bit of thickening at the side joints, but not as bad. But because you don't have a disc herniation at that level, you have that space. Even though you have facet hypertrophy, it's still narrower than it would be, but because there's no disc herniation coming into that space, it's freer. Now, as you go down in the lumbar spine at this level, so this is your lumbar multifidi. See this tissue? This is muscle tissue here. It looks like when you look at a steak, right? You see some of the fat.
I know, I've got the ribeye and I need the fillet.
This is a normal level, right? This is probably, these facet joints aren't thick, right? These are normal looking facet joints, and you have multifidus that looks pretty healthy. But let's look what it looks like down at the level of the disc herniation and the stenosis. And let's go down even lower.
But this is a year ago and I've been working on my core, right? You could change that, right?
So look at this level. Look at how much you have in here, right? This is fatty infiltrated lumbar multifidi. So when you have inhibition of a muscle, just like the BMO, if you get a muscle to be inhibited by pain, inflammation, surgical intervention, something that causes inhibition of the muscle, you'll get fatty infiltrating. That happens very, very, very quick after an injury. So how do you think this muscle functions to stabilize that level?
Doesn't.
Not very good, right? And what happens if it's not stabilized? What happens to the facet? You get incidental motion, so you get facet hypertrophy, you get stenosis, the cascade of events. So at this point, what do? Well, you can have some of that bony buildup removed by a surgeon, and obviously you can start working on your core. You can have a discectomy, which is another option here. Go back up to this disc herniation. This is probably the level of the dysfunction. This is probably the level that's getting you. And this herniation, so this, in the simplest form, you can cut a hole in the lamina, you can go in surgically, and you can take out that part of the disc. So now you'll have, just think about it, you'll have that much more space in your canal, and the neural framework will be that much bigger. So, are you a candidate for surgical intervention? Probably. You have a discectomy to take part of that disc out. Not necessarily fuse it, but definitely remove that much of the disc. Now your neural foramen is that big, and your lateral foramen will be that much bigger. You can see the nerve there.
So a discectomy as opposed to the laminectomy, or those
Well, you have to
different
have
options?
you have to have a laminectomy in there.
Oh.
So you have both. I think you would have, if it was just because of the set hypertrophy, you'd get away with laminectomy, but you're going to have a
Yeah.
So does this, the MRI kind of make sense, the pathoanatomical diagnosis from what you guys saw? Let's see.
You said the muscles started to look like they do at the lower level because of not being used.
Well, not being used. So you can have a back injury and less movement, you adopt new movement patterns, you don't use it as much. But there's a physiological process of when an area is injured. It doesn't matter if it's this is from research. They did the pig study. They took these pigs and they traumatized their disc, they traumatized their nerve roots, they traumatized the set joints, and all of the trauma led to the same thing: fatty infiltrating the muscle. So it doesn't matter what type of trauma. During the repair process or the injury process, the healing process, these muscles get inhibited. When they get inhibited, they start to deposit fat in the muscle, or fat gets deposited for some reason. But we do know with patients, if patients who do core stabilization, who aren't at this stage, that don't have the facet hypertrophy, don't have a disc herniation, but just have hypermobility, back pain from hypermobility, can retrain those muscles, and patients get better, and they don't have future episodes of back pain.
John, if you re-image somebody after a core training and learning how to properly fire up the multifidi and all that stuff, would you expect to see restoration of a normal look in the MR, or would you still see the fatty infiltrate?
That's a good question. And I haven't seen a single study that's done that because it probably doesn't cost.
My copay was $600 for this MRI. I'm not kidding. I mean, I said to Getson, I never want to have, I don't even care if it's before surgery. Like, I never want to have that. That's really expensive. That was my copay.
So, you can see, MRIs are expensive. So I haven't seen it would be a great case study to do before and after stabilization. But we know symptomatically, or ultrasound studies, let me put that back. Ultrasound studies have shown that when the degree of fatty infiltrate goes down, the patient's symptoms get better with ultrasound. So I haven't seen MRI, but I've seen lots of ultrasound studies. So yes, when people do specific core stabilization exercises, they get their fatty infiltrate, level of fatty infiltrate goes down, and their symptoms get better. And the reoccurrence is less, and they have less reoccurrence over time. So it's so important if a patient has back pain, regardless of what it is, whether it's a disc, they strain their back, they myofascial, whatever it may be, that you give them core stabilization exercises to do for at least 6 weeks. Any other questions about the case of the MRI?
So you're thinking I had an injury?
I think you had some reason why you developed this hypertrophy. This doesn't happen just by chance. It happens by stress. So you could have had an injury somewhere in your lifetime where you injured your back, significant enough to stretch the ligamentous structures around the back. And maybe you got some muscle inhibition, then you retrained them. You had motion cells that moved a lot. And over time, the bones got thicker. Maybe that's how the disc herniated. Maybe it's a chicken or the egg. Maybe the disc came later. The fact is, you have set hypertrophy, enlargement of the central, with central disc herniation, which is narrow spinal canal in the middle brain, and you have fatty infiltrates and muscles.
Should we mention the cortisone that I would like to run through my veins? Because it's really helped. I've had 2 cortisone shots. The first one lasted exactly 8 weeks. I'm already 10 weeks out, but 2 weeks ago I started having a lot more pain. So I don't know how many they'll do.
So you had epidural injections, right? Or facet injections?
I don't. It was Tony's and I don't think it was epidural. I mean, it was under X-ray and then under the needle. I don't know if it was like that.
Well, you usually do the epidural right in the office without fluoroscopy.
No, this was fluoroscopy.
So you have facet injections. So this is the 2 options for the patient. So the options for the patient had, did you have both or just facet? Just under X-ray?
Just under X-ray,
Okay.
I had 2. And within 3 days, my pain went from that 6 to 0.
Okay. Even in your legs?
Even in my legs.
So maybe because you generally don't get the relief of leg pain with facet injections. So two possibilities. What level does the spinal cord end? L1, L2. So what they do is they go in with a needle. They go posteriorly through the spine.
No, this is good.
So they go through the spinous. They basically have the patient flex down, go between the spinous processes and into the epidural space. And they inject steroid. The steroid kind of seeps down along the nerve roots of that area, and it helps the disc that's herniated, the nerve roots that are swollen and inflamed, and it will reduce basically the size, because cortisone is a autoimmune inhibitor, right? So it decreases the immune response, the inflammatory response, and everything kind of shrinks down. All those inflammatory mediators are dissipate, and everything calms down and basically provides more space for all those tissues. So the stenosis is actually lasting, even though the mechanical stenosis is still there, the tissues aren't swollen, and that's why it doesn't last
Right,
forever.
and the actual injection is really, really painful, but I would do it every day.
Unfortunately, you can only do in
Right.
3 a year.
3 a year.
And so so you can't get rid of it. The other thing is, though, he may have injected the facet joints. So if the facet joint is inflamed, and it's, you can inject cortisone right into the joint, and that's also a treatment. Or you can do a selective nerve block, where you inhibit one of the spinal nerves, not nerve root, but one of the branches of the spinal nerve.
Which branch? Yes, she knows. Which branch of which nerve innervates the facet joint? That you tried to stimulate when you did electrodes over the low back for treating back pain with tennis? What nerve were you used to do dorsal? Dorsal? That was what? Yeah, it's the posterior primary ramus. Goes to that facet joint.
So those are three options, but it basically inject an anti-inflammatory into the space, and it does give patients relief. Now, will it give long-lasting? Sometimes it's facet, if there's a facet dysfunction, but it's not really that hypertrophy, not that degenerative. Like for a young athlete who has extension back pain, it seems to relieve the problem completely. It will give some relief in the degenerative facet, but again, lost that smooth surface, you don't have a nice pavement anymore, it's potential to come back if those injections do come. Unfortunately, you have to change the mechanics. The only way when you can change the mechanics of the bone buildup is to remove some of the bone, or if there's a degenerative disc, to remove some of the degenerative disc. But it is extremely important to build up those muscles and do it for stabilization, because you want to limit the function. But now we've gone from an area of hypermobility, probably now stiff. Aged up almost 100, that's stiff. Because those joints are so thick, they don't move like they used to, so they're stiff.
Other questions? Does that make sense? Yeah? Hopefully in your mind too, you're starting to think of topics you want to educate the patient about. And this isn't different than a conversation we have with our patients. Pull out the MRI, pull out the models. Because now she knows, why do I need to do stabilization? What's the benefit going to be? And you're sold on that. How do I make decisions about injections? Should I have another one? And so all of this is part of education. There's probably other topics you're thinking of that you need to talk with her about. Continue running, how to monitor for getting worse, modifying her running. What kinds of exercises? Flexion. Core, and flexion. Do we ever want to work on extension? Yeah. We'd like to maintain our ability to extend, we just don't want to do it for long repeatedly. Be monitoring.